Now we are good to go.
Hi, good evening to all the doctors, Dr. Bhavna Parikh Madam, Dr. Bhairav Chaudhary Sir, Dr. Nirmal Raut Sir, Dr. Nilesh Damne Sir, and Dr. Ashwin Rajput Sir. We welcome you for this virtual longevity meeting or Lorla Tennis. Sir, before proceeding for the meeting, let me tell you, sir, please allow me to tell you the disclaimer. This meeting is exclusively for invitees only. If you have not been invited to this meeting by Pfizer, we request you to kindly log off. This meeting initiator reserves the right to block unintended recipients. Video or audio recording of this WebEx meeting is strictly prohibited. Now to all, I will welcome Dr. Bhavna Parikh Madam as a moderator, who is a consultant medical oncologist at Bombay Hospital and Medical Research Center, Lilavati Hospital, and Bharatiya Aragunidhi Hospital, Mumbai. Madam has achieved Best Poster Paper Presentation and UICC, International Union Against Cancer Congress, New Delhi, India. Madam has done training at Royal Marsden Hospital, UK, worked as a visiting fellow at Royal Marsden Hospital, UK, under Dr. David Cunningham, head of GI and lymphoma unit. Welcome, Madam, for this virtual meeting on board. Now, our case presenter, Dr. Bhairav Chaudhary Sir. Welcome you, sir. Dr. Bhairav Chaudhary Sir is a consultant medical oncologist, Kokilaban Dhirubhai Ambani Hospital, and he worked as assistant professor in medical oncology, DMMC, Nagpur, senior consultant medical oncology, Civil Hospitals, Amravati. Dr. Bhairav Chaudhary Sir has presented many presentations on a retrospective audit of clinical characteristics, treatment, and outcome of patients with gestational thromboplastic neoplasia. We welcome you, sir, for this virtual meeting. Dr. Ashwin Rajboj, welcome you, sir, for this meeting. Dr. Ashwin Rajboj, sir, is a consultant medical oncologist, Bharatiya Vidyapeeth Medical College and Hospital, Dhakanwadi. Dr. Ashwin Rajboj, sir, is a DM Medical Oncology at PD Hinduja Hospital, 2015-2018, and he achieved gold medal MIME, and he has published a number of trials within the oncology space. We welcome, sir, for this virtual meeting. Dr. Nirmal Raut, sir, we welcome, sir, for this virtual meeting of Lorlatinib. Dr. Nirmal Raut, sir, is a consultant medical oncologist of Bhaktivedanta Hospital Research Institute and in Mumbai. Dr. Nirmal Raut, sir, has done masters in molecular oncology, CNIO with European School of Oncology, Spain. Dr. Raut, sir, has done many major trials conducted, include non-Hodgkin lymphoma, DLBCL and FL, rituximab, metastatic triple-negative breast cancer, paclitaxel, among others. Sir, we welcome, sir. And last, Dr. Nilesh Damne, we welcome you, sir, for the who is a consultant medical oncologist, Kolhapur Cancer Center, Kolhapur. Thesis research study in hyponatremia in critically ill patients. And Dr. Nilesh Damne, sir, has achieved first prize in 4th MOSCON Molecular Biology Research Abstract Presentation Competition. Welcome you, sir, on board for this virtual meeting. Now let me share the agenda of this particular meeting. Dr. Bhairav, which will be starting by Dr. Bhairav Chaudhary, sir, who will be presenting case presentation, then followed by Bhavna Parikh Madam, Dr. Bhavna Parikh Madam, who will be moderating the session with all the panelists. So now I'll hand over the stage to Dr. Bhavna Parikh Madam to take over the session and to go ahead.
Okay. Thank you, Mr. Gupta. And I think let us start our scientific activity for today evening. And I will request Dr. Vaibhav Chaudhary to start his presentation on one interesting case that he is going to present to us. So
Yeah,
can we
thank
have
you.
Dr. Vaibhav Chaudhary, please?
Yeah, thank you, madam. Thanks a lot. Thanks, Pfizer. for allowing me to present this wonderful case. This is a very, very important case and very interesting one. I just sharing my slide. Is my slide visible to all?
Yes, yes,
Hello.
yes.
Yeah, fine. So this, yeah. So this is actually a case of ALK positive lung cancer, and this is a young chap. Actually, this actually is familiar. This is a young chap, 24-year-old patient without any comorbidities, presented with the headache and seizures to a neurologist. MRI brain revealed multiple metastatic lesions in right parietal and temporal lobe. Whole body PET CT showed a 3.5 into 4.5 centimeter FDG pleural base mass in right lower lobe with mediastinal lymphadenopathy, and also he had massive pericardial effusion. So patient was started on anti-epileptics, pericardial tapping was done, and fluid tested positive for adenocarcinoma. The CT guided lung biopsy was also done, which was suggestive of poorly differentiated adenocarcinoma. Patient was diagnosed as stage 4 adenocarcinoma lung with malignant pericardial effusion and multiple brain metastasis. Patient started on whole brain radiotherapy and had symptomatic relief. After completion of the radiotherapy, the patient was started on chemotherapy with paclitaxel and carboplatin. Biomarker tests EGFR, ALK, and ROS1 were performed on the tissue biopsy. Fish for ALK positive came positive, and that's actually typically a typical presentation of ALK positive lung cancer. Young patient, non-smoker, presenting with upfront brain metastasis. As good as around 20 to 30% of these ALK positive lung cancers do present with brain metastasis. So, as he was started on paclitaxel carboplatin, first dose was already given before the ALK report has come, and after getting the ALK report, patient was switched to tablet serotinib 450 mg per day from 4th of April 2016. So patient responded and had a very good clinical response to serotinib. Response assessment, CCT scan done after 3 months in July 2016 was suggestive of partial response with a reduction in the size of the lung mass to 2.3 into 1.3 centimeter and disappearance of pericardial effusion and brain lesions. Patient progressed after 15 months of serotinib with increase in size of lung mass to 5.2 into 4 centimeter and multiple bilateral lung metastasis. This time though, the brain lesion was stable. So patient was started on alectinib 600 mg BD from 13th of August 2017. Patient had an excellent response 2 months after starting the alectinib. All the lung lesions decreased with completely resolved, and no lesions in any other sites were detected. So this is kind of a complete response. And patient continued to respond to alectinib for 16 months before progression. Patient developed seizures and headache after actually 18 months. And the last CT scan was normal, which was done. But this time on evaluation after the seizure, the PET CT revealed widespread progression in the brain and lungs and reappearance of this pericardial effusion. So patient was admitted in a very sick condition in the ICU for supportive care. The case was discussed in tumor board and a decision was taken to re-irradiate the brain with 20 grays in 10 fraction dose was given, and patient had a good response to radiotherapy this time around, and CNS symptoms gradually started improving. But patient was still PS4 and had a massive tumor burden, not fit for chemotherapy. So patient was started on tablet lorlatinib, 100 mg per day dose through Pfizer compassionate program, though at that time lorlatinib was not officially launched in India. So we were lucky enough to get the Pfizer compassionate program from 4th of February 2019. We started the patient on this. Patient actually tolerated the treatment well and had gradual improvement in general condition. At 1 month post starting lorlatinib, his performance status improved to PS2. Response was actually good and patient kept on improving clinically and became PS0 in 2 months. A response assessment PET CT again showed a complete response in 3 months after starting the lorlatinib. Patient kept on responding and was symptom free. Response assessment scans were done every 3 monthly, kept on showing a complete response. But after 13 months of starting lorlatinib, the patient developed shortness of breath and had a massive pericardial effusion with no other active site of disease. Patient was advised, tapping was done and palliative procedures were done and was advised to take chemotherapy, but didn't start the same despite repeated counseling. He underwent a peritoneal shunt as a palliative procedure without much improvement in symptoms. His general condition kept on deteriorating. He had multiple bouts of infection and was on palliative care only. Disease also recurred in brain ultimately, and the patient ultimately succumbed to his disease due to progression on 20th May 2020, more than 4 years after the diagnosis with upfront brain metastasis. Purely, he just received 1 cycle of paclitaxel earlier, and after that, patient never received pemetrexed carboplatin. Maybe we could have actually achieved a better response if we would have been able to convince the patient to take chemotherapy. But with this ALK inhibitor, here the point to consider is that even after progression on lorlatinib, widespread progression where actually I personally, where patient came to me after progression on alectinib, and no one gave him a chance that he would be again up and about. So it was kind of a miraculous recovery from that point of position, and actually patient started going to his, he finished his actually college degree as well in the meanwhile, while on lorlatinib. So this is a big achievement that we actually never thought of would happen, and that shows the power of this drug. Thanks a lot for patient listening. I will now stop sharing my slides and we can proceed with the panel.
Thank you, Dr. Vaibhav sir, for your case study. Dr. Bhavana Parikh madam, can I share my slide? Hello.
Bhavana ma'am.
Yes. Yeah.
Dr.
So we'll go ahead,
Yes.
I think.
Yeah.
Yes.
Madam, with your permission, can I show these slides?
Yes, please. Yes, please. Yeah. Okay.
Yeah.
Thank you, Dr. Vaibhav, for this very good case presentation, because I think these are some of the points that actually we are going to highlight today. And can I have my slides, please?
Yes, madam. Madam, can you please confirm me you are able to view the slides?
Yes, yes. Can you make it slideshow?
Yes, madam. I have done that.
Okay, fine. Okay, great.
Thank you,
So
madam.
I think, first of all, I must thank the organizers for arranging this scientific program for us. And at the same time, I would also thank my other faculty members, to remain present for the discussion. So what we will do is that we are going through this whole slide set, and then there are also questions in between for my panelists. So I think let us start with my first slide. Next slide, please. Okay, so what we are going to cover today, of course, will be the lung cancer overview, and then CNS testing for CNS disease, managing CNS disease for this particular group of patient, treatment sequencing strategies, as I think which was highlighted even by the previous case presentation, and we will certainly focus on the new drug, that is lorlatinib, and its design and mechanism of action. And we are going to discuss the crown trial today in more details. And of course, we must always focus on the adverse events of any new drug that we are going to use. So this is going to be the flow of our panel today. Next slide, please. So next slide. So certainly, why are we discussing the lung cancer today? I'm sure that all my colleagues who are there today present for this meeting will agree that lung cancer is one of the major causes of cancer, not only the major cause, but also the reason for the deaths. If you see this Globocon 2020 data, you can see that the death rate of lung cancer is approximately 18%. And if you see the incidence of lung cancer, it is about 11.4. So we do see so many lung cancers in our day-to-day practice, out of which, of course, 80 to 85% of them are going to be non-small cell. So that certainly forms a major burden as far as our clinical practice is there. Next slide, please. And if you see again the incidences in India, it is estimated that as the our demographic in our country is changing with more elderly population now, and because of which it is the fourth most common cancer diagnosed in India today, which is just going to increase significantly in next 20 years. And those patients who are presenting to us with distant metastasis are almost 50%, or even sometimes I feel even more than 50% as far as our clinical practice goes. So many of our patients, we are not able to cure them, but we certainly have much better drugs available today. Next slide, please. Now, again, this is showing the what is exactly the data which is available in India. And as I highlighted that as the time goes in the next 2 decades, we are going to have significant number of lung cancer patients in our country. And if you go to see the estimate number of deaths, so if you see the lung cancer is the fourth most common cause for the mortality as far as our country is also concerned. Next slide, please. Now, what about the ALK mutation? I'm sure that all the oncology colleagues who have joined for this meeting will agree that the driver mutations that we really check for our patients, the maximum number of mutations are actually found in KRAS, EGFR, while ALK somewhere between maybe 5 to 6%, 7 to 8% averagely, depending on what scientific registry that we are studying. So this is approximately the second most common mutation that we find in our non-small cell lung cancer patients. Next slide, please. And if you really go to see the ALK rearrangements, very typically these are adenocarcinoma patients who have been non-smoker or very light smoker, usually a younger patient, as was seen in the case presented by Dr. Vaibhav Chaudhary also. And also we know that the patients who have EGFR mutation positive will not have ALK rearrangement and vice versa. So they are mutually exclusive driver mutations. And we also know that there are various types of fusion patterns that we see, out of which some of the fusion patterns like variant 3 are supposed to be very aggressive. Next slide, please. Now, when we see this kind of fusion, what exactly was detected initially, what is the inversion pattern that we see? The inversion is a type of gene rearrangement that occurs when a chromosome is broken in two places and the resulting piece of DNA is reversed and reinserted into the chromosome. Now, this particular rearrangement we see in chromosome number 2, and that causes the fusion of ALK gene with AML4 gene, and that results in AML4 ALK fusion protein, which is responsible for oncogenesis. And this was first reported in 2007, and there are various variants which are available for this particular fusion protein. Next slide, please. Now, so some of the questions that I would certainly like to ask my panelists are as follows. So my first question goes to Dr. Nirmal Raut. Dr. Raut, can you tell me what is the incidence of ALK mutated non-small cell lung cancer in your clinical practice?
Sorry, what's the incidence of ALK mutated NSCLC?
Yes, please.
ALK mutation would be not more than 5%. I mean, it should be 3 to 5%.
Yes, I think averagely that is the answer that maybe most of the panelists will give me. Now, the second question I'll ask Dr. Nilesh Dhamne from Kolhapur, that what is the preferred testing platform that you generally prefer at your center?
Yes, so now one tissue, one test, that's what we say instead of doing each separately. So initially we used to do EGFR separately, ALK cross, Now the definitely management pattern has shifted. So we like to do in one go. So nowadays we are doing 12 gene NGS most of the settings, and the TAT is around 2 to 3 weeks, and that quite affordable also. So we are as of now using NGS panel to do a
Yes.
complete lung gene panel. Yes, and PDL1 is separate.
Yes, yes, correct. And previously we used to ask for fish test and all, but now I completely agree, and I think most of my panelists will agree that we all have shifted to selective lung panel NGS, which is available to all of us. And when you see the reports and if there are some particular type of variants mentioned, does it change your treatment, Dr. Vaibhav Chaudhary?
Frankly speaking, ma'am, not much at this moment, because obviously, since the data has come for lorlatinib and crown trial, which obviously we are going to discuss, it's undoubtedly the most broad spectrum ALK inhibitor present right now. And also in terms of PFS and OS as well, actually it will be higher than any other. So if we are thinking of first line of lorlatinib, obviously it will not change in quality as well as quantity of life. Both will be better with lorlatinib. So for me, if I'm using lorlatinib first line, it doesn't impact my decision at all.
Yes, correct. Actually, averagely for all the options, we don't have any variant specific data available. So ultimately, whatever variants we may see, ultimately we would choose the drug, which is a broad spectrum kind of a drug. But as I discussed earlier, also the variant 3 is supposed to be the aggressive one. But of course, we are not choosing the drug based on the type of variant. Okay, I think let's go further. Can I have the next slide, please? So, what exactly is the problem with ALK positive diseases? We all know that these are the patients who are generally young, non-smokers or light smokers, and the biggest problem is the CNS disease. CNS metastasis is seen in almost 20 to 40% of untreated ALK positive patients, and that certainly leads to poor outcomes for these patients. And also, we have been using second generation TKIs up till now, as shown even in the previous case that we have used ceritinib, we have used alectinib, and so on and so forth. But we know that all these tyrosine kinase inhibitors, as and when we are using, there is definitely development of mutations, further mutations, and these mutations are actually responsible for the resistance that we see to these drugs. And also, these medications, the previous second generation TKIs, failed to achieve much response or much control of CNS disease. So, this is our biggest problem as far as ALK positive disease is concerned. So, what can be ultimately done for this? Next slide, please. So, also one important clinical point is that shall we screen our patients for CNS disease at presentation? Next slide, please. So my colleagues will agree that most of the regulatory authorities or the guidelines, if you will see, the NCCN certainly recommends that we should do the MRI with contrast or the CT with contrast. So my question goes to Dr. Ashwin Rajbhog, that do you screen all your lung cancer patient at baseline or you are selective?
So, my majority of patient I screen at baseline.
Okay, and
Just
you also
see
prefer MRI or you prefer CT?
MRI brain is what I prefer.
Yes, yes. It has. There have been some comments that MRI may not be easily available, but actually in our country, it is available at most of the places at a reasonable price. So I think all of us will be doing MRI for our patients. Next slide, please.
So just one thought, I totally agree. By NCCN, by all the guidelines, we should get a contrast enhanced MRI brain for staging. But most of the times, once we suspect stage 4 disease, we get a PET CT done most of the places. And if CT is
Yes,
absolutely
I agree.
normal,
But
yeah,
most of the PET scan reports, they would pick up some brain disease, but sometimes they do miss out on very small lesions or some of the activities. So, honestly speaking, it may be still worthwhile doing MRI brain, according to me, because when I discussed with my nuclear medicine consultants, they feel that they may suspect some lesions, but the clarity of number of lesions or extent can be picked up only by MRI brain. So maybe it will be more helpful for exactly knowing the disease burden. That is my personal view on this. But you are right
Actually,
that PET scan will pick up the disease. That's true.
yeah, if
So
PET scan is negative, then chances of MRI picking are still 5 to 10%. But then
correct.
always a discussion whether we are going to treat or address those, even if that MRI pickup which CT has not shown no perilegional edema. Just
Yes,
the
yes,
sake of discussion. Yes, ideal is
yes,
MRI, but
yes,
I found very difficult to convince patient once PET CT is done and
correct.
get on unless it's small cell lung carcinoma.
Yes, that is true. Yeah. No, I mean, I try and do MRI brain with contrast for most of my patients because, we may miss out on some of those lesions. That's what I feel. But you are also right in what you are saying because practically sometimes it is difficult. Now, this is just a comparison between MRI and CT, but I think all of us are convinced that we must do MRI. Next slide, please. Now, managing the disease at the point of diagnosis, if you already have a patient who has brain metastasis, as we saw in the previous case presentation. Next slide, please. Now, we have choices because the patient might have a symptomatic brain metastasis or patient might have an asymptomatic brain metastasis. And if the patient had symptomatic brain metastasis, what we saw even in our case presentation where patient actually presented with convulsions, etc. So these are the kind of patients where usually some form of local therapies will be required. And otherwise, when we are evaluating our patients and if we really find them ALK positive, and we are going to start some of these patients on the say third generation TKIs, then we can avoid giving radiotherapy at that time. But also another problem with whole brain radiation could be again cognitive dysfunctions, etc. Because at this moment of time, with the use of better drugs, we are looking at the longer survival for our patients. So another option for our patients also could be some form of stereotactic radiotherapy if it is possible, if it's a small number of lesions. Next slide, please. So yeah, I'm sure that all of you know that NCCN guidelines actually recommends that all the three drugs, that is alectinib, brigatinib, and lorlatinib, all the three have category 1 approvals, and also ceritinib is still approved, and for crizotinib, it is written as useful in certain circumstances. So, towards the end of our presentation, we'll try and see whether we still want to give crizotinib in some of our patients. So I'm going to keep that question in reserve. Next slide, please. Now, let us understand that treatment sequencing strategies for this ALK positive non-small cell lung cancer patients with CNS disease. Next slide, please. If you see this particular slide, then there are two algorithms which are given. So one is, of course, that we straight use lorlatinib for our patients and have longest, at least progression-free survival, of course, followed by chemotherapy. And the second option could be that yes, we can still wait for second generation TKI. We can use it. Patient will be responding for some time, but patient will develop resistance, and then we will be using lorlatinib in later lines of treatment. And then, of course, the patient may be offered chemotherapy. So the thing is that ultimately, which is the better way of treating our patients. Next slide, please. Now, if you see the patients who have got the CNS disease, and suppose you are suspecting CNS problem, whether one accurate way of characterizing CNS disease is even by doing liquid biopsy through CSF analysis and tailoring the treatment based on the molecular profile that we may find maybe lower the risk of rapid CNS deterioration compared to a blinded treatment switch. But I really wonder whether we are really able to do this kind of analysis on CSF in our routine practice. So I will ask Dr. Nirmal Raut whether he has come across any patient where he really needed to do such a thing.
Um, yeah, yeah. I had patients where the CNS disease was there, and we had to do CSF, and we did find some mutation in the CSF which were positive for ALK mutations.
Okay.
So ALK kinase domain, there were mutations with the CSF, so
Yes.
we definitely gave them that.
Okay. So those patients did not have any brain parenchymal lesions. That's what you are trying to tell me.
No, there were brain parenchymal lesions also.
Okay.
And this
Okay, fine. But you have used in some patients.
yeah,
This.
some patients are used.
Okay, okay, fine. Okay. Next slide, please. Okay, so if we really summarize only this part of the talk, that newly diagnosed patients, ALK positive lung cancer patients, non-small cell, the incidence is about of brain metastasis is about 20 to 30%, and the all the guidelines recommend testing for CNS metastasis at diagnosis, preferably with MRI with contrast. And several ARC TKIs, they have been evaluated as first-line therapy for ALK positive non-small cell lung cancer with CNS disease, and they have demonstrated prolonged progression-free survival and intracranial efficacy. And ultimately, it is the lorlatinib, which is a kinase inhibitor, indicated for the treatment of adult patients with metastatic non-small cell lung cancer whose tumors are ALK positive, detected by FDA-approved test. In the first-line setting, lorlatinib has the potential to manage and prevent the emergence of CNS metastasis, and better understanding of prognostication is required to help identify the patients who would benefit from therapy and to inform treatment sequencing algorithms. Next slide, please. So even if we have, choose one agent over the other, there are a lot of questions which come to our mind. And then the question comes that which is the better of all the agents available today. Next slide, please. So let us focus on lorlatinib, which is the point of discussion today, and we'll just go through briefly over the drug design and mechanism of action. Next slide, please. So basically, lorlatinib is a third generation ALK TKI, and it has a selective ATP competitive and highly potent third generation ALK TKI. It has excellent brain penetration of 75% to address brain metastasis and improved clinical outcomes with overall and intracranial activity in patients with previously untreated ALK positive advanced non-small cell lung cancer. And upfront treatment can completely suppress or at least significantly delay on target resistance, leading to more durable clinical benefit. Next slide, please. Now, if you see these two most important points about lorlatinib on the right hand side of your slide, you can see that important characteristics is that it has a very effective CNS penetration and retention. The CSF levels of lorlatinib are really high. And not only that, as I mentioned, that if we use second line TKIs and then use lorlatinib, these patients also develop multiple ALK resistance mutations. And lorlatinib has a very high affinity for most of these mutations, because of which it will be effective even in presence of ALK resistance mutations. So these are the two most important characteristics of lorlatinib. Next slide, please. Next slide, please. Yes, so now this was the rationale for evaluating lorlatinib in the first line therapy, because we already had enough data of phase 2 therapy showing significant benefit. And it also gave us the clinical activity in patients whose treatment failed on first as well as second generation TKIs. And in untreated patients, results suggested that lorlatinib may eliminate rare pre-existing subclone harboring ALK resistance mutations or delay the emergence of such resistant subclones. Next slide, please. So now we'll study the phase 3 CROWN trial. Next slide. So CROWN trial, the study design was simple. Basically, the patients with stage 3B or 4 stage ALK positive non-small cell lung cancer patients were recruited, and they had no prior systemic treatment for their metastatic disease. The performance status was good, 0 to 2, and they could have asymptomatic treated or untreated CNS metastatic disease. And patient must have one or more than one extracranial measurable target lesions with no prior radiation required. So basically that is to follow up the responses. The randomization was 1:1 with lorlatinib dose of 100 milligram per day, as you are aware, and crizotinib 250 milligram twice a day. And this was, the patients were further stratified by presence or absence of brain metastasis and by ethnicity, that is Asian and non-Asian. If you go to see the primary endpoint was progression-free survival by blinded independent central review. And secondary endpoints were progression-free survival by investigator, overall response rate by BICR as well as investigator, intracranial overall response rate, duration of response, intracranial duration of response by BICR, and intracranial time to progression also by BICR, and overall survival, safety, and quality of life. Important point in this trial is that no crossover was allowed. So that is something which is important. Next slide, please. If you see this particular slide, and if you see both the arms, that of lorlatinib and crizotinib, the arms are fairly well balanced, and the brain metastasis was present in about 26 patients in lorlatinib arm and about 27 patients in crizotinib arm. And if you see averagely all the other parameters, they are well balanced. Next slide, please. Now, first let me discuss the 18 months follow-up data. Next slide. So this has been already published in New England Journal of Medicine in 2020. If you see the primary endpoint, which was the progression-free survival by BICR, now if you see the progression-free survival at 12 months, it was 39% for crizotinib, while it was 78% for lorlatinib, and median progression-free survival in months was 9.3 for crizotinib, but it had not reached as far as lorlatinib is concerned. So in this interim analysis, lorlatinib significantly prolonged progression-free survival compared with crizotinib, with hazard ratio for disease progression of death, which is significantly come down. Next slide, please. Now, if you see progression-free survival even by investigator, the similar picture is seen. Again, median progression-free survival of 9.1 months with crizotinib and not reached with lorlatinib, and hazard ratio of 0.21. Next slide, please. And in subgroup analysis, if you select any subgroup which is based on performance status, ethnic origin, presence or absence of brain metastasis, or smoking status, etc., for all of them, the lorlatinib arm was something which definitely improved the results as compared to crizotinib. So progression-free survival benefit of lorlatinib over crizotinib was consistently observed across pre-specified subgroups. Next slide, please. Overall response by BICR, if you go to see, the overall response rate was about 58% as far as crizotinib is concerned, and it was 76% for lorlatinib arm. And if you go to see median duration of response, which was about 11 months for crizotinib, that means patient developed another lesion at the end of 11 months. While if you see lorlatinib, it has not evaluable, not yet reached. So significantly more patients in lorlatinib arm had an objective response compared with the crizotinib arm. So that is also significant as far as our patients' quality of life is concerned. Next slide, please. And similar picture is also seen as far as intracranial overall response is seen. If you see the intracranial overall response rate, then again, as far as the crizotinib arm is concerned, median duration of response is only 9.4 months, while lorlatinib not evaluable. Median time to response is similar in both the arms. It is 1.8 months for crizotinib and 1.9 months for lorlatinib. So lorlatinib demonstrated significantly higher intracranial response rates compared to crizotinib. In this slide, on the left-hand side, you can see the difference for the patients who had measurable or non-measurable brain metastasis at baseline, and the patients who had measurable brain metastasis at baseline, which is depicted on the right-hand side. The benefit is seen similar in both the groups. Next slide, please. Second important question is that what is the time to CNS progression, especially if you have patients who have no CNS disease at baseline. What is the time to CNS progression, which is always our worry in ALK positive patient. So if you see that in the intention to treat population, the time to CNS progression was significantly lower with lorlatinib than with crizotinib, with hazard ratio coming down to 0.07. If you see the crizotinib arm, the patients with event were about 45, while that of lorlatinib were only 5, and median time to CNS progression was again 16.6 months in crizotinib arm, by again not evaluable or not reached as far as lorlatinib is concerned. So these are the patients without CNS survival without CNS progression. Next slide, please. Now, if you see the cumulative incidence of CNS and non-CSN progression at first event. Now, if you see again, there is a vast difference between both the groups. If you see the cumulative incidence of even CNS progression at first event, then lorlatinib arm, if you go to see, the incidence is only 2.8% vis-a-vis crizotinib, which is 33.2%. And if you go to see non-CNS progression at first event, the lorlatinib arm, it is about 15.4% vis-a-vis crizotinib, which is 44.3%. So there is a very big difference in all the graphs that you can see. Next slide, please. If you go to say overall survival at the time of this 18 months data, the OS data was still evolving. So we are not able to see the significant result in this graph. Next slide, please. Regarding the safety, more or less the drug can be managed, but I must highlight here that if you go to see the grade 3-4 adverse event, they were higher in lorlatinib arm compared to crizotinib arm. But the adverse event leading to permanent discontinuation or temporary doses interruption were not very different as far as lorlatinib and crizotinib arms. So what it means to me as a clinician that we need to learn how to manage these adverse events, and in that case we should be able to continue lorlatinib for most of our patients. Next slide, please. So if you see the adverse events which were more than 10% difference in frequency, the most important ones being hypercholesterolemia, hypertriglyceridemia, edema, and the weight gain. So these are some of the most important adverse events that I would like to highlight as far as lorlatinib is concerned. And as clinician, we all have to learn how to manage these problems. Next slide, please. Now, as far as the quality of life is concerned, the patients who had received lorlatinib, they had a much better quality of life compared to the patients who received crizotinib. Next slide, please. Now, at the same time, we are now having additional follow-up data of total 36 months. Next slide, please. Again, the primary endpoint, which was progression-free survival by BICR, and you can see over here that the progression-free survival for crizotinib arm was again 9.3 months vis-a-vis lorlatinib, which was still not reached at the end of even 36 months. So if you see, then there is a significant difference between the two arms, even at the end of 36 months. Next slide, please. Again, subgroup analysis. All the groups are more or less favoring lorlatinib. Next slide, please. And if you really see the patients, there are two graphs on this slide. On your left-hand side, you can see the patients who had baseline brain metastasis. Even for these patients, if you see the median progression-free survival was only 7.2 months with crizotinib, while with lorlatinib, it had not reached. Similarly, on your right-hand side of your screen, you can see the graph, which is patients without baseline brain metastasis. And these patients had progression-free survival of 11 months with crizotinib, while it had not reached with lorlatinib. So as you can see that both the groups have benefited significantly. Next slide, please. Time to intracranial progression, again, similarly, we have hazard ratio of only 0.08. So there is a large difference. Time to progression, crizotinib 16.6 months and lorlatinib not reached. Next slide, please. And if you go to see BICR assessed intracranial time to progression in patients with baseline brain metastasis, for crizotinib arm, it is only 7.3 months vis-a-vis lorlatinib, which has again, it has not reached. Next slide, please. And if we go to see BICR intracranial time to progression in patients without baseline brain metastasis, These patients, crizotinib median progression-free survival was 30.8 months, while again for lorlatinib, it has not yet reached at the end of even 36 months. And if you see the events, only one patient after 112 patients on lorlatinib developed brain metastasis compared to 25 patients as far as crizotinib is concerned. Next slide, please. And these are the summary of overall and intracranial responses with both the agents. And you can see that for all the groups, lorlatinib is significantly better than crizotinib. Next slide, please. And adverse event, again, as I highlighted, that the grade 3-4 adverse events are certainly more, but the discontinuation rate or permanent treatment discontinuation rate are almost similar, or maybe numerically little bit higher in crizotinib arm. Next slide, please. Safety profile, again, these are the metabolic parameters that we need to take care. That is hypercholesterolemia, hypertriglyceridemia, edema, and weight increase. So these are some of the important things. Also, these patients can also develop peripheral neuropathy, which also we need to keep in mind. Next slide, please. Okay, so again, this is the same thing which is highlighted, that if you really see the patients even at the end of 36 months, the permanent discontinuation is almost same whether it is crizotinib or it is for both the things, that is 18 months as well as 36 months. Next slide, please. So key takeaways from the CROWN trial are that with approximately 18 months of additional follow-up, that is total 36 months, the lorlatinib continued to show superior overall as well as intracranial efficacy compared with crizotinib in patients with ALK positive non-small cell lung cancer, and progression-free survival by BICR remained longer with lorlatinib than crizotinib, and 3-year rate being 63.5% with lorlatinib vis-a-vis only 18.9% with crizotinib, and time to intracranial progression was also significantly longer with lorlatinib than crizotinib. And these efficacy benefits with lorlatinib compared to that of crizotinib were observed not only in patients with baseline brain metastasis, but also in patients without baseline brain metastasis. And in patients without brain metastasis, only 1 out of 112 patients exhibited evidence of intracranial progression, suggesting a protective effect against the development of brain metastasis on lorlatinib treatment. So this is something which is very important, especially for all younger patients that we see. No new safety signals have been raised. So these updated long-term data from the CROWN trial confirm the efficacy of lorlatinib over crizotinib in patients with treatment-naive ALK-positive non-small cell lung cancer, and support the use of lorlatinib in these patients with and without brain metastasis. Next slide, please. So now I would like to have input from my all the 4 panelists, that what are your impressions of the data from the CROWN trial, and how likely is it to impact your choice for the first line therapy for your patients with or without brain metastasis. So maybe we can start with Dr. Vaibhav Chaudhary. Dr. Chaudhary is around? Okay, then maybe I can ask Dr. Nirmal Rao. Dr. Raut, I am not able to hear you.
Okay, I will share my view. So
Okay.
yeah,
Yes.
definitely
Doctor,
appears is a
yes.
game
Yeah.
changer. Yes, yeah, last week only I had a discussion with the Pfizer medical team. I had a
Okay.
patient who's a ALK positive by IHC.
Okay.
Fish was awaited.
Yes.
Some symptoms of lung disease, disease limited to lung, liver, lymph nodes, and bone. There is no any disease in the brain.
Okay.
And we got just updated data of CROWN trial. And the only concern was roaming around everywhere on medical groups about the headache and CNS side effects or lorlatinib. And just got
Correct.
an email from Pfizer also about how to tackle this. So even if
Correct.
patient doesn't have brain disease, the lorla has a good action in the brain. As we say, it could prevent the possible meds, but it may
Correct.
come at the grade 1 or grade 2 side effect of headache, dizziness. So I
Yes.
think yes, it's high time we should reconsider that our practice change to directly next generation TKIs like lorlatinib, I would say, irrespective patient is a brain mets. And
Okay.
I would say yes, Lorela and Crown trial is means still PFS and OS is not met yet. So I
Correct.
would say this is quite a instead
Yes.
of starting with a first or second generation TK and then shift on further progression, like what we saw the first case. So
Yes.
patient did well to the 4 years, which is good in 2016. But after three change in TK, so every time he has to undergo scanning and the counseling for the next TK availability, adjustment, everything. So yes, upfront with a single molecule, I would say that we should reconsider our strategy of starting first line ALK inhibitors in a stage for NLCLC.
Okay. So Dr. Ashwin, would you like to add some comments?
Yes, I would also definitely agree to what he's saying. Especially in our regards to count trial, we have seen, especially in all set, may it be subgroup analysis or may it be PFS, definitely this lorlatinib benefits over crizotinib. Apart from the side effect profile, what we have, that also you can see the drug discontinuation rate was more or less similar. And again, the same question and the same thing regarding the CNS side effects. And now that we have three agents in the first line setting,
Correct.
whether to go ahead with alectinib, brigatinib, or lorlatinib.
Yes.
So we the same situation. Lorlatinib is new drug. We don't have a lot of
Yes.
experience with lorlatinib. But again, that things regarding first screen patient for brain metastasis, and if brain metastasis is there, then better go ahead with lorlatinib rather than saving it for second line.
Yes.
This dispute is still going on, but again, with the amount of mutations which might happen later on and which may prevent by starting it upfront in first line, I think
Okay.
definitely lorlatinib is a better option.
Yeah. So the crux of the matter is that we just need to learn. To manage the side effects. I think that is the crux of the
Yes, yes.
matter.
Like
I
if,
think
if
that is
you
the
can
main
say,
thing.
if you can see percentage wise, more than 50 to 60% of hypercholesterolemia
Yes.
increase of weight gain more than grade 3 weight gain in about 20-25% of patients. So definitely it
Yes.
is going to hamper the quality of life when we compare it with other same setting indicated ALK inhibitors. And apart
Okay.
from that, more than 20% of patients having those cognitive and mood dysfunction. So we
Yes.
need to tackle it. Whatever I have read, most of those side
Yes.
effects are reversible either by dose adjustment or over a period of time it goes. So practically, we could get a better gist by using it rather than
Okay.
thinking over it.
Yes. So I think, yeah, thank you. So I think we'll also discuss these things in next few slides. Next slide, please, Mr. Gupta.
Ma'am, just wanted to inform you, Dr. Vaibhav is also, he was having
Yeah,
some technical issue, but he
I
has
think
joined back.
yes, yes, yeah, no problem. We'll discuss, we'll ask him further questions. So can we go to the next slide, please? Yeah, so these are the recommendations, which I think all of you know, nothing much to say. Next slide, please. Okay, so this was meta-analysis which was done for the lorlatinib first-line treatment of patients with ALK positive. This was presented in World Conference on Lung Cancer in 2021. Next slide, please. Okay, so here also, they probably felt that lorlatinib is an effective first-line treatment for ALK positive patients as compared to crizotinib and other next-generation ALK TKIs. But we have one more very interesting meta-analysis coming up. Next slide, please. But of course, as mentioned earlier also by my panelists, that we do not have much data about the difference in the overall survival for most of these agents. So it was immature for most of the studies which were included even in this meta-analysis. Next slide, please. Okay, so this is one very interesting meta-analysis which is there by Wang et al. And I'll just show you a few more slides, but it says that in terms of progression-free survival, the results indicated that lorlatinib was the best treatment choice for patients with ALK inhibitor naive or untreated. That means patient has not received chemotherapy, patient has not received any ALK therapy. These also advanced non-small cell lung cancer, and future head-to-head trial assessing the relative efficacy of lorlatinib, alectinib, and brigatinib are probably required. We obviously have all the data compared to crizotinib, but let us just try and see what they found in this meta-analysis. Next slide, please. Okay, so here we know that results from this meta-analysis, including only randomized clinical trial with head-to-head comparison with crizotinib, indicate that the first-line lorlatinib is still the best treatment choice for progression-free survival. And lorlatinib shows a significant progression-free survival advantage even vis-a-vis brigatinib and alectinib, with a probability to reach the best progression-free survival of 97.5%. And it also improves the progression-free survival for both the groups. That is the group which was absolutely untreated, all the patients who were ALK inhibitor naive patients. Next slide, please. So if you see in this chart on the left-hand side of your screen, you have a subgroup analysis with alectinib, and then you have on the right-hand side, you have a subgroup analysis with brigatinib. And most of these subgroups are again favoring, more or less they are favoring lorlatinib. Next slide, please. So conclusion of this network meta-analysis was that lorlatinib significantly improved progression-free survival than brigatinib and alectinib, with hazard ratios being 0.57 and 0.59 for ALK inhibitor naive patients. And in terms of progression-free survival, the results indicated that lorlatinib was the best treatment choice for the patients with ALK inhibitor naive or untreated ALK positive advanced non-small cell lung cancer. And among the lorlatinib, alectinib, and brigatinib and crizotinib, lorlatinib had the highest probability to reach the best overall confirmed response rates and intracranial confirmed response rates, but no significant difference was found among OS, that is overall survival, and adverse event analysis. Next slide, please. So now I think we have discussed most of these things, so we'll be going ahead. Next slide, please. Okay, so let's focus on the adverse events, which is our worry to some extent because it's a new drug. Next slide, please. Okay, so now first question is about the hyperlipidemia. I mean, whenever we are treating these patients on lorlatinib, then we need to check the lipid profile at baseline and then again at first month and second month. And we need to use the lipid lowering therapy and monitor these patients closely and advise the patients that hyperlipidemia is managed and resolvable through lipid lowering therapy and dose modifications. So this is something which is important. So I personally feel that the patient education about this toxicity is something which is very important. Next slide, please. And this is the dose modification guideline for hyperlipidemias, that for more or less patients who are managing with cholesterol, say even up to more than if they go of the mild category, then usually we can introduce the lipid lowering therapy, but we can continue the same dose of lorlatinib. Only when the patient really have severe hyperlipidemias, that is cholesterol more than 400 or triglycerides more than 500 to 1000. Now these are the patients where we might have to become little bit more aggressive, but we may be able to continue lorlatinib without interruption. But in life-threatening hyperlipidemias, we have to introduce the lipid-lowering agents and we have to withhold lorlatinib dose until these settle at least to moderate category. And in that situation, we will also, whenever we are introducing the lorlatinib again, we are going to reduce the dose by 25 milligram. That is the one dose level little lower. So let me ask Dr. Vaibhav Chaudhary that whether he has come across such a patient where, this was a very challenging task or he had to stop the lorlatinib or anything of that sort.
Not till now. Actually, I have been lucky and fortunate that I have actually treated 3 patients only on this one, and all of them tolerated at full dose. I did check for hyperlipidemia at 1 month and 2 months, and one of them actually required lipid lowering agents, but then it was well managed. And after some time, actually, patient stabilizes, and
Correct.
it is not such a big challenge to manage the lipids.
Correct. Okay, fine. Next slide, please.
So this life threatening, I've never had to interrupt my doses for that. Yeah.
Okay, yeah, that's a good input, I think. Next slide, please. Now, regarding the CNS effects, as already discussed by some of my colleagues already, these CNS effects are a little bit tricky. The tricky reason being that number one, sometimes these patients might have already received radiotherapy, cranial radiotherapy. So that is one thing which might contribute, though actually it's a long-term side effects. And secondly, they might have a baseline brain metastasis. So these are little tricky. Now, changes in cognitive function, mood, and speech. These we need to really, explain to the patient's relatives so that they can pick up these things a little faster. They are generally mild in severity, intermittent, and they will improve or resolve once the dose modifications are done. And these adverse reactions were reported at a frequency of about 39.7, with 11.9% of the patients experiencing more than one type of CNS effect. So we have to be careful about these effects. And baseline CNS metastases were present in majority of these patients who got this problem. And a total of 24 patients required more than one dose modification as a result of CNS effects. And 15 of these patients experienced resolution of their CNS effects. The median time to resolution after stopping the drug was about 12.5 days. And the recurrence of CNS effect upon re-challenge at the same dose or reduced dose occurred in 6 and 7 patients in this group. So whenever we are monitoring our patients, we have to tell the relatives to be careful and inform us immediately if they find some changes. And otherwise, we have to sometimes stop the drug temporarily. So, Dr. Raut, you have come across any patient of this kind?
Yeah. I have used lorlatinib in many of my patients. Can you hear me?
Yes, yes.
Yeah. And I had a variety of symptoms. One patient had lot of weight gain, and one patient had CNS effects. So I had to reduce the dose for her. And all the
Okay,
patients had hyperlipidemia,
okay.
almost all of them had hyperlipidemia.
So they had hyperlipidemia even at baseline, or they developed when you
No,
used
developed
lorlatinib?
when we gave
Okay,
lorlatinib.
okay, okay, fine. Yeah, okay, yeah. Thanks for your input. Next slide, please. So this is the for the CNS effects, the dose modification guideline. And again, if they're very mild, you can just withhold the dose. The patients will probably recover, and then you can re-challenge with the same dose. Or if you are concerned, then you can certainly reduce by one level. But if they are really moderate or severe, we have to withhold till the adverse events reach grade 1, and certainly re-challenge only with one dose level reduced. But if there is some serious problem, then you might have to discontinue lorlatinib permanently. So important thing is to instruct the patients and the caregiver to report any changes in cognitive function, mood, or sleep, or their speech immediately to the treating oncologist. Next slide, please. Okay, so I think yeah, these are some of the other questions also which we comes to my mind, that when the patient is actually progressing even on any of the TKIs, do you really do rebiopsy of these patients, and do you believe that there is an unmet need in this area, and what can be done better for the best patient outcome? Now we will be addressing some of these issues, and then we will take inputs from our panelists. Next slide, please. Okay, so most important thing is the resistant pattern in these patients. Next slide. So resistance to second generation, like we all have been using second generation TKIs, and it has been seen there are multiple types of mutations which develop when we use these agents and when the patients progress. And most common being the G1202R. This is one of the most common ones. Next slide, please. And if you see, this is the chart. It looks little complicated, but what this chart is showing us that if you try to see the cellular level of all these drugs vis-a-vis various types of mutations, especially G1202R, which I mentioned, which is the common one. If you see, the lorlatinib requires the intracellular concentration of lorlatinib requires very less amount of drug. So what it is trying to tell us is that the lorlatinib is a potent agent against all the ALK resistant mutations compared to various other second generation TKIs. Next slide, please. So these are various mechanisms which have been seen. So some of them are ALK dependent and some of them are ALK independent. I think we have seen that when we have treated our patients and when we have re-biopsied and sent the tissue again, some of the reports do come back to us with EGFR mutations or PIK3CA mutations, and then we have to change the treatment completely. So we all have seen this in our patients. Next slide, please. And when the important issue is that, as we saw in the case presented, that when we try and use the various lines of ALK TKIs, the progression-free survival starts reducing. So even when lorlatinib, whether it is used in the first line, second line, or beyond second line, if you can see, the progression-free survival really diminishes. So the important thing is to use it probably upfront. Next slide, please. And this is how this is exactly the same thing which is presented even in this. If you see these graphs on both the sides, as more generations of ALK TKIs were sequenced, more monster ALK resistant mutations appear, and so it becomes difficult, even probably even by the newest agent, that is lorlatinib, to overcome all these resistant mutations. So we must try and use this little bit early in our treatment paradigm. Next slide, please. So if you see this particular graph, it is interesting to see that when you are using various agents like crizotinib and then second line TKIs, we have a smaller progression-free survival. Another option is that we can use alectinib followed by lorlatinib, but again, as you can see, the PFS is very short. And if you use lorlatinib as a first line, the progression-free survival is not reached. So that is the advantage of using lorlatinib. And then, of course, subsequent lines of therapy can be discussed with the patient, which is a different ballgame. So we'll not discuss now. Next slide, please. So these are the important key takeaways, that is in the treatment naive of ALK positive non-small cell lung cancer compared to crizotinib in first line. Lorlatinib resulted in a significantly longer progression-free survival, higher overall and intracranial response rates, improved global quality of life. The safety profile of lorlatinib is also, as we already discussed, that if we are able to explain the anticipated problems to the caretakers, and if they are able to tell us the in beforehand as far as the CNS profile is concerned, or about the hyperlipidemia, as my colleagues discussed, that they have been able to take care of their patients. So safety profile, we need to learn. For example, when we started giving immunotherapy, none of us was very confident about managing immunotherapy in those toxicities. Today, most of us are quite confident doing it because we all are always in learning phase. And although grade 3-4 adverse events were more frequent in lorlatinib than crizotinib, the majority were asymptomatic and readily managed. So with sequential ALK inhibitor treatment, approximately 35% of patients will develop compound ALK resistant mutations on lorlatinib with a solvent form of especially ALK G1202R containing compound mutations, and which may become the most common on-target resistance mechanism, and they are predominantly refractory to all known ALK inhibitors. So basically, these results support the use of lorlatinib as an effective first-line therapy for patients with advanced ALK-positive non-small cell lung cancers. So now my last question to all my panelists is that will there be still any clinical practice patients where you will still prefer crizotinib? So we'll start with Dr. Vaibhav Chaudhary.
Yeah, actually, not scientifically. There is no sense in just going for crizotinib upfront because we have so much data about alectinib and lorlatinib. The real fight is between alectinib and lorlatinib. But the poorest of the poor lot, which actually Pfizer is still supporting, I guess, with compassionate access.
Yes.
So those patients actually, that is a lifeline for them. So apart from that, I think the Crown data itself shows that lorlatinib is several times better than crizotinib.
Okay. And any other of my panelists would like to give their comment whether we want to use crizotinib in some particular case? Not all patients, but would you prefer crizotinib over lorlatinib at this moment of time? Dr. Nilesh, Dr. Ashwin, Dr. Nirmal Raut, anybody wants to give any comments? I personally feel that probably there could be only one reason, that if we really are not able to manage hyperlipidemias, or there are some patients who have some disorders of lipids, where the lipids are staying very high and not controlled even by rosuvastatin, etc. Probably this could be the only patients where today we will probably look for crizotinib, or really severe CNS problems. But otherwise, I agree with Dr. Vaibhav Chaudhary that given a choice, we would prefer lorlatinib, which has improved the outcome, especially because of the prevention or prolonging CNS disease. That is what I personally feel. So next slide, please. So I think this was my last slide, and I really thank all my panelists for participating actively. And I will hand over the mic to the organizers now.
Thank you so much, Dr. Bhavana Parikh, madam, for a very effective session on lorlatinib, the management of ALK rearranged NSCLC as first line. Madam, just to reiterate about the lorlatinib assistance program, we have got for ALK positive patient, we have got 1+1. Patient has to purchase the first box. The subsequent next box will be free as assistance from the company.
Okay, so what could be the effective cost ultimately for the patient?
Effective cost will be the 1.25 lakhs.
Okay, per month.
Per month. If I calculate the into assistance program, the effective
Yes.
1.25 lakhs.
Okay, okay, fine. So, how many patients as such in India must be taking lorlatinib at present? Like, you have any Indian data or anything?
Indian data, West particular region, I can say the West particular region, almost 15-20 patients are currently on lorlatinib. 20-25 patients are currently on lorlatinib, especially for West.
Yes.
And North and East also, they are getting good number of patients. I need to check with the absolute exact number from them.
Yes.
But discussing the Crown data, madam, overall, this molecule has a good acceptance. I think lorlatinib as a molecule has a good acceptance.
Yes.
Among all the doctors which we have discussed on the field, and like you and other doctors, this particular molecule, what we understand from the doctors, is a drug of choice for ALK positive patient.
Yes, correct.
So, ma'am, just to answer your query, like on first line setting, all India currently we have almost 24 patients who are taking lorlatinib as a first line, and all India more than there are 300 patients who are enrolled on like second line or subsequent therapy. But since you have disseminated the data about first line setting, so this is the latest data. In last 6 months, we have enrolled almost 24 patients, and out of that, in Maharashtra, we have currently Maharashtra, Gujarat, and Chhattisgarh and MP. We have currently 8 patients ongoing who are on first line therapy, and they have got complete response within an average rate of 2 to 3 months.
Okay, and I mean, yeah, that is what I think Crown data also showed, that average duration for response is 2 months.
Yes,
so
ma'am.
That is what I think most of the doctors must have seen. So, is there any adverse event signal or any report that you have received in these patients when it is being used in Indian patients? And I hope that you are also documenting the data for Indian
Yes,
patients.
ma'am. So whenever there is an adverse event other than the LPD or mentioned in local product document, first of all, we have to report that. But two things which are coming most frequently, which is coming, is hyperlipidemia, which you have talked about. So we have a data till where the patient limit has gone to 500 also. So
Okay.
that can be also manageable with rosuvastatin, and we have seen the patients, hypercholesteremia level, cholesterol level is going to 330, 340, 350 also. But
Correct.
doctors are managing that with rosuvastatin. And we are recommending with rosuvastatin because both otherwise atorvastatin and lorbicua both are metabolized through same enzyme. That is
Correct.
why we
Correct.
are not
Yes.
saying atorva, and rosuva can manage it better.
Yes.
In 5 to 10% of patient, there is a like hallucination or that kind of neuro side effects which are observed. In 10 to 15% of patient, yes, doctor have shared about their inputs on that
Okay.
also, but they are
Okay.
saying that then in those cases they will ask patient, means they have then their own protocol to make that
Okay.
alternate therapy for 10-15 days.
Yes.
But over the period of 1 or 2 months, that side effect of hallucination or sort of CNS side effects, that also goes away.
Okay. Okay. Fine. So there are no new safety signals as far as Indian population is concerned.
Yes, ma'am. So
Huh.
whatever the side effects are there, that can be seen in the initiation of the therapy for next 2 to 3 months, and then it will subside.
Okay. Yeah, correct. Yeah, it settles within a short period of time.
Yes, doctor.
Yeah. So
Yes.
by that time, I think if you have, say, already documented response after, say, 2 months, 3 months, I think that
Yes.
is the time where the patient also actually settles, with the toxicity part, most of them. And then if you've
Yes.
documented good response, then of course you will continue the treatment for these patients.
Yes, doctor. Yes.
Yes, yes, correct. Because
So
I think, as far as I know, that in the Crown trial, in Asian population, there is no Indian data. If Indians were not included, or
yes,
were
ma'am.
they? Yeah,
Yes, ma'am. That is why
yeah,
we have shared this Indian data, that how many new
correct, correct.
patients on first
Yes,
line setting.
yes, yes. So I think that is important. I think
Yes,
so.
ma'am. Yes.
Yeah, correct.
And if
So
all the panelists, including you, Vaibhav sir, Nilesh sir, Ashwin sir, and Nirmal sir, need this data of hypercholesteremia, we will ask our medical to provide that data also to all of you, ma'am.
okay, so that should be good. I think, yeah.
Thank you.
So I think, yeah, I think
Yeah,
maybe we
I
can.
just would like to call upon, ma'am, our vote of thanks by Nilesh Gadge. Nilesh, over to you
Sure,
for the PAP, and yeah.
sure, sure. Yeah.
So, thank you so much, Dr. Bhavna Parikh, for the elaborated discussion on the usage of lorlatinib in ALK positive NSCLC patients and management of those patients. Most important thing is that you have discussed about the side effect profile of the patient, because whenever you are using any new drug, side effect is the concerning thing, which is you need to, or we all need to take care of. So, from behalf of Pfizer, I wanted to thank Dr. Bhavna Parikh, Dr. Nilesh Damne, Dr. Vaibhav Chaudhary sir, and other two doctors. So thank you so much for the wonderful discussion, ma'am, and thank
Okay.
you for all the support, ma'am.
Yeah, thank you so much. I think it was a fruitful discussion. So I think we all enjoyed. Okay, thank you.
Thank you, ma'am. Thank you all the panelists, doctor, and other attendee doctors who have joined this particular meeting and spent their valuable time. Thank you, ma'am. We'll be certainly doing this type of activity in the coming months also, and we need your valuable feedback. Thank you, ma'am. Have a nice day.
Thank you, Dr. Ashwin sir.